Welcome, everybody. Today's webinar on meeting the challenges of diabetes, working with non-English speakers with diabetes. I am Pata, Quality Improvement Specialist with UCare, and this webinar is brought to you by the 6 managed care organizations called the Collaborative, which impacts the SMBC and MSHO population. This performance improvement project, also known as the PIP, focuses on improving comprehensive diabetes care and services. All health plans across the U.S. serving Medicaid members are required to do a PIP. DHS collaborates with us to establish this as a priority project, and all the health plans already have multiple interventions in place. The PIP allows us to formalize this work, collaborate on interventions, and bring them statewide. This project must be designed to improve the quality of care and health outcomes, address a serious condition, and improve member satisfaction, all with the goal to achieve significant improvement and sustained over time. This PIP addresses all of these areas. The webinar is being recorded and will be available for viewing later on the Stratus Health website on our Health Plan Performance Improvement Project, Improving Comprehensive Diabetes Care page. There will be an evaluation at the end of this presentation, and it will be displayed as you log off. During today's presentation, please submit your questions via chat, and our presenters will respond to the questions as time allows. It is my pleasure to introduce our guest speakers today. First, we have Hilda Sanchez Herrera, nationally certified healthcare interpreter and a Minnesota Community Health Worker certificate holder. She has worked with a variety of Hispanic cultures and healthcare professionals. Currently, she is a contracted CHW working with CHW Solutions, doing telehealth visits for clients. Ensuring meaningful access to medical and social services is her passion. Hilda will speak to how language and cultural differences impact diabetes care, the role of CHWs and interpreters, how they are different and where they intersect, and the role they play in reducing barriers.
Hello, everyone. Thank you for having me. I appreciate this opportunity. Thank you to CHW Solutions, Health Partners, and UCare for this opportunity. As Patang mentioned, I am a nationally certified Spanish healthcare interpreter and a Minnesota CHW certificate holder. At CHW Solutions, I work with diabetic patients via telehealth visits, and I connect patients to resources. I do follow-ups as necessary, and I share feedback within a clinical team. And part of my presentation today will be a little bit of a storytelling and real-life encounters. The stories will bring to light some of the challenges that I have encountered as a CHW in different areas of my work. So I'd like to ask you to please keep an open mind, and ultimately, my goal is to show that clinicians, interpreters, and CHWs are allies, all working towards the same goal, a healthy patient and a healthy community. So I will begin by sharing a story that I read in a book promoting the health of the community. It is Yami, and she is a newly introduced CHW promotora in a clinical setting. She shares her story as working with a single elderly patient with congestive heart failure and poorly controlled diabetes who had recently had his leg amputated. What I like about her story is that it resonates quite a bit with a lot of the experiences that I have encountered and some of the things that I have seen in my work as a CHW and also as an interpreter. Two roles that I would like to keep separate and distinct. So Yami begins. I started working with a clinical team. I would hear them talk about a patient a lot, but finally I got to meet the patient myself. He had congestive heart failure, type 2 diabetes, his sugar levels out of control, and he had lost one of his legs already. First visit with patient. Nurse and social worker try to see what's going on with the patient and trying to see how they can help him out. So they talked to him. They explained the program and they told him, you need to take your medication. Towards the end, patient finally talked and asked if someone can help him apply for IHSS. Social worker said, okay, we can help you. And then we had to leave. Second visit. As soon as we got to the home, we can totally tell the patient was very angry and he kept saying, I went to the doctor, but he didn't listen to me or what I had to say. And he kept trying to say more, but one of the professionals stated, okay, but now I need you to check your sugar. Patient apologized and did it. His sugar levels were over 500. Patient tried to talk again about what was happening. They let him talk for a little bit, professionals looking at each other, making faces, rolling eyes. Then they continued to explain to him about his sugar being so high and why they refer him to a diabetes class. Patient stated, I will go. During the week, I hear the team talk about the patient saying he is not being adherent with medication. He is not listening. He did not go to the diabetes class. And someone stated 2 more visits. If not, we drop him. Over the weekend, patient went to the emergency room and he was released to skilled nursing facility. The social worker and I went to visit him and finally I was able to talk to him alone. Not even 5 minutes, but I was able to talk to the patient. I was able to explain really quick what I do and he opened up. He started telling why he was so mad and upset and how he lost his leg. He had no support system whatsoever. He was alone. Then my coworker was making faces to me like, hurry up, cut it, let's go. That's when I realized working in the clinical setting, it was not going to be easy. On my way out, I was telling my coworker he needs support. He said, yeah, I know. But I didn't say much more because his response was not too nice. Then later in the day, he asked me, why do you think he needs support? I told him what the patient shared with me, and he said, next time we visit him, you can take resources for him. The next day, the nurse care manager was upset because patient didn't make it to his appointment. And later during the day, patient called and he didn't want to see no one anymore. The team agreed to drop him from the program. All I heard was that in less than 3 months, he will be in a better place. That was very sad to hear. All he wanted and needed was someone to listen. And I told the social worker, but she said, he is out of the program. This patient was struggling after the loss of his leg. He never had counseling for that. He was mad and angry and he was alone and had no one to talk to. During those visits, I can see him crying for help, but he didn't get it. All he heard was people telling him what to do instead of asking, how do you feel? How do you cope with not having a leg? Or even asking how you lost your leg. Patient had so much to share, but no one listened. I was very limited in what I could do. It was a learning experience, not what I was expecting, but I learned that my job is very important and that my community needs us CHWs. Here, Yami's stories end. And the comment in the book is, all he heard was people telling him what to do instead of asking, how do you feel? The wisdom in these words are critical and should be a lesson learned in the delivery of healthcare. CHW promotoras get to the root of the issue and empathy and the ability to help patients connect. So taking that example into perspective, I'd like to kind of share some of the challenges that I have seen working with diabetic patients. For instance, newly diagnosed patients will often say, I feel fine. I ignore it and it goes away. I don't pay attention to it. Sometimes I do feel bad, but I just eat a little something and it goes away. Then comes the misunderstandings, and these are from the Hispanic point of view. And usually it's first generation immigrants. These individuals are not really aware of some of the health conditions. They see other family members with these type of conditions, but they always think it's not going to happen to me. So they're very unfamiliar with the illness. They don't really understand it. They think that it's temporary and not really long-term, especially when they hear that a pregnant woman had gestational diabetes, and then after she gave birth, it went away. So that becomes a norm for a lot of our patients. Oh, it'll go away. And also when we tell them that they're pre-diabetic, that even though we try and explain to them that they're still an opportunity for them to have changes in their lifestyle, their eating habits, so that way they can avoid becoming diabetic. Sometimes this serves as motivation, sometimes it does not. And they'll just say, okay, I feel fine. I don't need it. I don't have it. I'm okay. Excuse me. And many think that it can be managed and controlled without medications. And in some cases, this is true. It can be managed without medications, but the ones that have it pretty advanced or high A1Cs, those are the ones that we need to convince to stay on their medication in addition to their lifestyle changes and good eating habits. And that can sometimes be a challenge. A lot of them also do home remedies like moringa tea and Herbalife. Herbalife is very popular amongst the group that I work with, and it's sold as a natural juice, a natural tea, a natural supplement. So they take it thinking that it helps, and in reality it might, but they don't give it as much credibility as everything else that is offered or prescribed to them to help manage their diabetes. They also are very interested in doing natural juices, but some of their like smoothie type juices, but some of them don't recognize that carbs affect their numbers. So even though they're thinking they're eating healthy and it's all natural and it doesn't have sugar because it's fresh, the fruits and vegetables that they're using in their smoothies eventually affects their numbers. But once we get them to understand which ones they can do and which ones they cannot, or how much and in moderation, then they're a little bit more comfortable and they continue with their smoothies, their juices. They also self-medicate a lot of times because they don't really trust our health system. They want family members to send a medication from their country for XYZ. Sometimes they even send them injections thinking that it's a cure-all for everything. And that's where we kind of have to go in as CHWs and explain to them to try not to do that because it will affect their overall health in the long run. As the story that Yami shared, there is a little family support, and that's just mainly to reiterate the above comments of them being unfamiliar with the illness and that it's okay, it'll go away. So they don't really pay too much mind to it. And it's not until they are in the hospital or they start having severe issues that it starts becoming a focus and a concern and a motivation for them. And for some, even then, it's still not enough. So, and another thing that I see is the challenges with them taking their medications. A lot of them work 2 or 3 jobs. Sometimes they are single parents, single families. They don't know that a prescription is ready for them at the pharmacy. They don't know to look at the label to see if they have any refills left. So as a CHW, we come in and we explain that to them. And it's very helpful because we can say, okay, you only have 1 refill left. Go ahead and pick that one up, and I will let your nurse know that you need to get a new refill from the doctor. And at that point, if they have anything else that they're sharing regarding their numbers or their way that they're feeling, I gather all of that information and then I take it back. I take it back to them and talk to the clinical team about it and then let the team handle it from there. The other thing that I've noticed with medications, and it's also a challenge in keeping them focused, is sometimes they can't read. They have low literacy, or the label is English only, or the label is half English, half Spanish, or the label is written in poor Spanish, that they're so confused they don't even think about it. I had one patient take his medications for about 2 months, and then he felt fine. So he stopped taking them, and it's now been it was 7 months before he came back because his sugars were really high. He was in the hospital and they put him back on the medication. And he kept saying, well, I felt fine. I didn't need to take medication. I don't have diabetes. It went away because I felt fine. So we had to do a little bit more education. We had to help him see and do a little bit of motivational interviewing to be able to get him involved with his own health, to get him to see that he didn't have enough money to pay for his hospital bill. And in order for him to not keep accumulating so high bills, he needed to do something about it. And one of those things was to start taking his medication, start eating a little healthier, and start working on losing a little bit of weight. And we've been following him for a little while, and he's been doing really well. Which brings me to the next topic, food. Sometimes when we refer patients to a dietitian or a nutrition class, a lot of the times the food is not ethnic specific, and it becomes hard for them to relate and how to implement all of that with their culture. We tell them, okay, don't eat a lot of rice, don't eat beans, limit your tortillas, limit how much bread that you can have. You can have bread with your coffee, but the type of bread that they're eating is like a pastry bread, sweet bread. And we become a little bit more focused on those things and not so much the slices of bread that we're used to associating what is on the My Plate or what is on the classes in diabetes. So we have to help them see, okay, well, you can take this and this and this, but not like you're used to in a plate that's sky high. You can still eat it, but it has to be more leveled. It has to be smaller portions. And then once they see the connection between food and being able to still retain their culture and their normal way of eating, then they're a little bit more in agreement with staying on top of their care. The other thing is some of them have told me, well, I'm tired of eating salads. I don't want to eat any more salads. Now I'm ready to go back eating to what I'm used to, my tortillas, my tamales, my, gorditas, my pupusas. And I'm like, okay, well, that's good, but you can't go back to eat the way you used to. You can still eat them, but not as much. And the information that they sometimes get in those classes is too high for them to actually comprehend. In the interpreter world, we call that register. And the interpreters can keep a certain register and don't really bring it down too much. That is the clinician's job. So the interpreter will just kind of keep things as they are. And if the clinician hopefully is paying attention to their visual cues and to their mannerisms, then they'll see that, oh, they didn't understand what I said. So hopefully they'll rephrase it a different way so that the interpreter can go ahead and relay a message that the patient can understand. With the advancements in technology, we have the sensors, the glucose monitors, the sensors are a little expensive, but the glucose monitors, there's a variety of prices. But even then, it becomes a financial burden for them because and also a technology burden because they don't really have the tech savviness that most of us do, or at least this generation has. And it takes a little while to learn, and sometimes that's frustrating. So we have to be patient with them and teach them that it's okay to take it little by little, and that we will walk with them along the way until they feel comfortable enough to do it on their own. And basically, that is what a CHW does. We walk with the patient, we share in their successes, we cry with them in their defeats, but we also are there to motivate them, encourage them. You could do this, you can keep going. And it's a really beautiful relationship and connection that we have with them. And that is something that some clinical teams do not recognize just yet. There is another example that Yami shares regarding being asked to do the job as an interpreter. So Yami shares an example of when she was given freedom and time to address the patient's most pressing priorities, which were in the peri-clinical realm, and not so much the social determinants of health. So, no, I'm sorry, I said that wrong, which were the peri-clinical world of social, not medical determinants of health. Because staff in her healthcare system valued what she did and said as a CHW promotora, she was able to establish a trusting relationship with the patient and eventually earn the ability to influence the patient's medical priorities. And here's what she says. I had another patient who was going through a divorce with his wife. He was the first patient I have ever had that really got on my nerves. Because he was so negative, and I don't know what happened between him and his wife, and I don't ask or try to take sides with him or with her. But I just know that this divorce was really stressing him out, and he was so sad and down, and he was really nervous and anxious about going to court. He was also the type who had never done a thing for himself before, and he didn't know what to do. I tried to help him with a lot of things and show him how to do it himself. So he asked me if I could represent him, and I said, no, I'm not an attorney. Then he said, well, can you come and be my translator? And I said, no, they have special people who do that for a living, but we can ask for one of them to help you. What I can do is go with you and be there in the building to support you. So I did, and he was so thankful and grateful and appreciated it so much. So being an interpreter has its role, it has its place, and it should be used by all facilities to the best of their ability. CHWs are unique. We are bilingual. We are in the community. We have insight and knowledge into the culture, into how health systems work, into how social services can be obtained. And we can bridge a lot of those needs and communications with a lot of people and make healthcare meaningful and accessible to all those who need it. So if you are going to use an interpreter as a CHW, I would highly caution the use unless they are trained. If they're not trained, then by all means, get them trained. So that way they can know the difference in their code of ethics and also their standards of practice. In this particular illustration, we have an iceberg, and the iceberg shows a lot of the things that an interpreter and a CHW will take into account. The very top item is food. We all associate food, music, language, visual arts, festival, whenever we talk about culture. But there's so much more to that than just so much more to that. So an interpreter actually has 4 roles. They have a conduit, a clarifier, cultural broker, and an advocate role. The CHW role has 10, but I'm going to highlight 4 of them. They are a bridge. They connect social determinants of health or address social determinants of health. They're a cultural broker, and they're also an advocate. So even though an interpreter and a CHW have similar things, their roles are quite different. The little square at the top on your screen lists the 10 roles that a CHW will do. And that is way more than what an interpreter can do. An interpreter can only do the 4 that you see here, and it has to stay within those boundaries. And if you really want to make an impact in healthcare, in meaningful access, and in connecting or helping eliminate some of the disparities, it's important to incorporate and integrate CHWs in teams as much as possible. Learn how to work with them. Both of them have the same qualities, Here it says core CHW qualities, but an interpreter shares the same thing. We're compassionate. We are community-oriented, patient-oriented. We are self-directed. We're motivated. We persist. Both work for the good and the common welfare of the client. It's just in different avenues. So towards the end, sorry, I'm getting nervous. We share common perspectives, as you see, and we have the same qualities. So CHWs can help in so many ways. Let me get that other, okay. Let me share one final story that Yami shared. Yami gives a good example of a physician who has learned from and appreciates her CHW promotoras with the following story. This perspective ties it all really well, and I think I'll end with that. I just love my doctor. Well, I call her my doctor, but the doctor on our team. We really work great together, and she gets it. Now that we have been working together all this time, she really understands what we do as community health workers, and she is always wanting me to see so many of her patients. But then, unfortunately, the team tells me I can't see them unless they're qualified with their insurance and stuff. But anyway, this doctor is so great, and she really has the heart to help her patients. I told her, you are practically a community health worker yourself, because she is always going the extra mile to help her patients. Sometimes she even brings in gift cards for food and things like that because she really cares about her patients. And now she sees that they have all those other needs besides what they come to her for. So even some clinicians recognize the value of having CHWs on their team. We do make a difference. We do help bridge necessities. We make connections. We provide education. We can clarify things without time constraints. We build trust, allow for openness. We discover the underlying issues that are sometimes not spoken in clinic appointments. We can see how they live, what they need, and also be able to help them overall. It's really a beautiful thing to have. And CHWs are interdependent because we rely on the clinicians to help us better help their patients. We recognize our limits as well. So we all have a different variety of training, and that is good. And we do our best work outside in the community, outside of the clinic. And as long as we do not maintain a narrow focus, we can reach so many people and do so much good. So we all know that diabetes is very debilitating, and we're all trying to work together for the common good. I hope this was helpful, and thank you for your time and attention.
Thank you, Hilda, for sharing your stories and wisdom. Again, please, through via chat, post your questions. We will have time later to have some questions with our presenters. Next, we have Marie Sherwood, UCare Health Coach, a national board certified health and wellness coach and tobacco treatment specialist. She coaches in UCare's disease management department, where she works with members with a diabetic or migraine diagnosis. She holds a master's degree in health education and physical education. Marie has been a health coach for the past 11 years, with the past 5 years at UCare. Her purpose is to empower the member to move forward in their health journey to achieve higher levels of health, gain control, and a greater awareness of self and well-being, supporting members to build their self-confidence and helping them make better lifestyle choices. Her background also includes over 20 years of clinical care with patients as an exercise physiologist for a neurology clinic for patients with neurological conditions and injuries. She's helped her patients reduce pain, restore function, and gain back a better quality of life. Marie's experience in healthcare involves working with people from diverse backgrounds, where she works to understand the needs of the member and meet them where they're at in their journey. She uses language interpretive services daily to provide her coaching services and has used them in all of her career positions to provide health coaching and patient care. Marie will share her experiences coaching non-English speaking members.
Hi, and thank you very much for asking me to participate in this presentation to the PIP group, Emily, Patong, Patty, Jerry, and Jenna, thank you so much for asking me to help share information. You can go ahead and turn the slide there, Patong. So first of all, I'll start off with what is health coaching. And just to kind of share some information, you might see some similarities or crossovers between the CHW and a health coach. But in my role, I work in partnership to explore and guide a member to try to also inspire them to improve their health and wellness. We look at trying to help an individual define a vision for health. We look at their behaviors and thoughts, and we try to help them identify areas for change to help achieve this vision. And through this process, we use a variety of different coaching techniques. Motivational interviewing would be one that you are probably aware of. But we explore reasons and readiness for change. We connect them to their values and needs and try to help them identify resources, if possible, that we can help them with. We look at revealing strengths and identifying steps they can take. And this is their strengths that from past experiences of things that they've taken on. We also empower these members by highlighting and turning on the light of these past experiences to help build their confidence. So through this process of working on small step change, this empowerment also takes place through the coaching process as we follow up with the individuals when they're working on their goals and steps. We also believe that the member holds the answers to the challenges that they face, and we guide them through the journey of change. And what that means is that we don't tell them what to do, we guide. So if we give them information, we usually ask permission to do so, as that's kind of a guide for us as coaches, that we're not being the direct educators in this path. So we operate a little bit differently than care coordinators or case managers or CHWs, because we believe that through the conversations that we have, that we will identify kind of where the individual needs to go. Okay, Patong, you can change. As Patong said, I use the language line, and it is not without its challenges, but it's the way that we engage with our non-English speaking members. We at UCare have to use the language line to communicate. And this does involve a little bit more work. To work with an individual usually takes longer. So we will schedule an hour appointment, usually with our members when we have actually engaged them and they've agreed to participate. Prior to participating, we would have outreach attempts based upon maybe a referral that's come in or an interest that's come in that they've responded to, or we may do a cold call in outreach for the diagnosis of diabetes to share and offer information for support. The initial conversations, usually when we're engaging somebody or recruiting them, can take anywhere from 5 minutes to a half an hour, depending on the individual and kind of trying to meet them where they're at. So this is one of the challenges, is that it can be very time consuming when we have to push and try to make a lot of calls in a day. It can kind of be a challenge in that we're having to go longer than we would want to than an English speaking member to recruit them. We also will at times have to pre-arrange calls with a specific language interpreter if a language is not a common language. And sometimes that can be more challenging because it involves a back and forth with the language company that we work with. When I do engage with the interpreter on a set call, I ask to have the interpreter's name. I ask them to pronounce it for me. And I ask them if they would please pronounce the member's name properly for me. And then when I am introducing myself to the member, I also ask them to speak their name so I have a better understanding of how to speak their name. When I am in the call with the member, I also will ask for clarification in the conversation. If I've asked a question that seems to be having a very lengthy response, I will actually stop the interpreter and ask the interpreter to explain why it's taking so long in the answer. And it may just be because through the interpretive process that there isn't a way to interpret the question that I asked. So we reframe the question and start over. But that takes my ability, because we work telephonically, I have to kind of listen to the nuances of the call. I have to listen to how the member is responding. And sometimes that can be easy to understand, and sometimes it's not, just listening to how an individual speaks. At times I can request an interpreter. Also, if a member has had a good experience, I will often ask to use that particular interpreter again, and that has to be granted by the language line. I always give thanks for the time. Thank you for the participation. Thank you for sharing. I ask permission always to give information, to verify information, to be able to have this conversation. And this is kind of a guideline for us with motivational interviewing techniques. Okay, Patong, you can switch. How we engage with an individual that's non-English speaking, as I said, can be challenging. So as I said, we make outreach calls to identified and referred members with our language line. When we reach the member, I ask permission to speak to the member. I will verify their information and explain who I am and explain why I'm calling. Now that can be easier said than done. When there's an expectation from a culture that I'm supposed to give the information, I'm supposed to give the advice, I'm supposed to tell them what to do. So explaining what a health coach does can be confusing even to English-speaking people. So what I try to do is, in the introduction to health coaching, is that I usually share with them that I'm offering support, and that we look at helping individuals make changes. And I usually ask them what's their biggest issue, what's their biggest medical concern about their diabetes or the health condition, to try to understand where they're at. And I also ask them if it's okay if I can ask these questions. So letting them know that they're part of this role. It's not just me asking a million questions. I try to be also very concise in the questions, so I don't ask many questions over and over, and I try to listen to how the responses are going with an individual in the contact that I have with them. When we actually do engage these individuals and enroll them, they are set up for coaching conversations, a call every 2 to 4 weeks. And I usually will go more frequent than I do with English-speaking members, because the retention can be poor if I have not done a good job in establishing rapport with the individual. If I haven't listened to what their needs are, I really need to be listening deeply to understand what they need and look at how to best support them. Okay, Patong. So some of the tips here that I would say that are helpful is that we use motivational interviewing as a primary source of a coaching technique in meeting the members where they're at. And what that really involves is the ability to use open-ended questions, reflections, and summary. So like the ORS technique for motivational interviewing is very helpful. I try to listen and reflect to have a better connection, to establish better rapport with the individual. We are always meeting the member where they are at with their health and readiness to change, and I'm not pushing an agenda upon them. I fully well know their blood sugars are really high. They may not be taking their insulin, but I'm not pushing that to direct that's where we need to go. I may guide through questions, but it always is driven by where they are at and with what's important to them. We use a balance of assessment tools, and we help move the members towards recognizing what their needs are. And we look at how to support them and help them self-manage in their health. And as I said before, we try not to give all the direction. We really need to have the individual working with us, collaborating in a partnership. I do coordinate with case managers and care coordinators when possible, especially if I need help coordinating care to get to a dietitian, a nutritionist, or somebody like a diabetic educator to kind of help with medication. We do have some rules as far as what we can and cannot do, and giving information about medication or nutrition. We try not to take an expert role in what we're doing. We also need to kind of honor the presence that we have with an individual and kind of honor how they are reacting to the conversation. I noticed the other day in a scheduled 45-minute initial interview, we schedule an hour, and so I had given this information up front that this would be a lengthy call, but I noticed during this call that the members seemed to be shortening up the responses, and so I just said, I'm wondering, if you could tell me how you're doing right now I know I'm asking you some questions and you've kind of agreed to answer them, but how are you doing? And this individual person was a Somali individual, and it was kind of funny. And they said, well, I've never been on the telephone this long ever in my life. And I said, oh, wow. Yeah, that might seem like a lot of questions. Yeah, this is a lot. I said, would it be helpful if maybe we stopped and scheduled this again in a couple of weeks to go through some more questions? And they said, oh, I'm so glad you said that. So glad you said that. Thank you. Yes. Thank you. Thank you. So we did. And we moved on to another appointment. And just by listening to it was nonverbal, but it was through the phone, maybe the expression of a sigh or whatever, I was able to kind of understand that this individual, my agenda was to get it done, but I needed to really meet this individual where the person was at. And had I steamrolled through that, I probably would have lost the rapport with this individual. Go ahead, Patang. Also, our tendency is to think that we have to follow a scheduled protocol where we have to do these calls once a month, or they have to be so many minutes long, or we have to get this assessment done. I try to be attentive to, I need to establish rapport and retention. So I try to do these calls, as I said, closer together, maybe once every 2 weeks instead of once every 3 or 4. Sometimes my schedule doesn't allow for that. So I might need to ask permission, ask if they understand that they would be having an appointment. And so getting them to agree to that is also can be a challenge, but looking at what's important to them and try to help them move forward with what's important. When members ask me to do things for them, this can be challenging because there's a cultural thought that I need to do for them. So I really have to take a breath sometimes in this moment, and I need to understand that this is just the normal way of living for them. So they're expecting I'm coming from health insurance, or I'm coming from a medical field, and that I would have the answer, or I would give the direction, or I would give the advice. And so what I redo here is I really kind of reframe and redirect some of these questions. And I might ask them, okay, what's one step they might be willing to take? So I might kind of bargain with them on what they're willing to take. I might be able to help them with this. And so we kind of work together to keep that partnership, so I don't lose the balance that I'm the expert and they are less than me. I want to keep them in this frame of mind that we both are on the team, okay, and that sometimes both people paddle down the river, sometimes one person paddles down the river. So I try to explain to them and try to work with them on that. It doesn't always work that way, but it's important to try to help them understand that I don't always give the education. I also ask these individuals what's the best way for them to learn? And what have they learned? Like, for instance, have they seen a dietitian? What did they get out of that? So I have a very curious conversation about what's the doctor said, what's the dietitian said, have you done this? Kind of just to understand that. If they have access to the internet. And one of our challenges is that most of our resources are in English. So I will ask if there's an English-speaking family member who would be willing to read through some information or go through some information with them. or I will need to kind of interpret some information if it comes up in the conversation. So it's usually always about them and not whether I think they should read a book or not. Let's see. I also explained to them how to reach me, okay, by calling me back with my telephone number and saying their name if they can. And if they can leave their phone number, I will know they're on my list and call them back. I try to train them to do that. So because most of them take a very passive role in connecting with me. So I try to help them with that. I also ask them if they know their care coordinator, if I see that the individual has an active case, that if they understand how to reach that individual or not, and oftentimes they don't. Okay, Patang. Let's see here. Okay, so in kind of the how do I do this or what do I do with the individual, I'm really trying to get to the what when I'm working with an individual. And I might have a conversation with an English speaking member that might take me 20 minutes to get to the what, or longer, just peeling layers back of an onion in a curious conversation using open-ended questions to kind of understand it. I try to be very direct in what is the biggest concern that you have right now with your diabetes. Or can you tell me a little bit about, your interest in talking to a health coach? Or can you tell me a little bit about, why it's important for you to look at change? And so I get to the what is the issue? I try to get that right away. And we try to get to what are the reasons that you want to. This is the motivation. Why is this important to you? And I have to be very careful about using why questions also. So why questions are often formatted in a what question. What would be the biggest reason for you why you would want to make a change like this right now? Would be an example of a open-ended question that's a why question. I commonly hear, as Hilda had said, there's a lot of miscommunication, there's misunderstanding, a lot lost interpretation at times. But I often will hear them say that I don't know what to eat, and I fear that it's going to get worse, and I need you to tell me what to eat. So it is hard. It's very hard because I can't go that route and directly tell them when I clearly know what they might need to do. So I need to kind of resist that. I resist giving the advice, and I really need to try to come to a place where this individual understands what they can do and help empower them to take a step that they can do. So this is where we build the confidence, we build the rapport with this. I will review and explore understanding of what actions and directions, as I said. Oftentimes I hear there is no education that they've received or they didn't understand it. I uncover strengths and past experiences and challenges that they've had. And uncovering strengths is really important because oftentimes, just in general, people don't realize that their past experiences are strengths. And so we want to try to highlight that and shine a big neon happy light on what has worked for you in the past. Tell me one thing that helped you. Who was there in your life? Okay. What type of rapport or relationship did you have with your doctor? What are the small steps that you took? So we try to understand and reveal some of this in the conversations that we have, especially in coaching. It may not be so much in the introduction call, but it might be more in the actual coaching process. And it's always about believing that the member has the answers within them, okay? And not everybody is appropriate for coaching, and I may need to refer them to get more education, but I don't let go of them as a coach until I know that they have the resource that they need to support them. Okay, next slide, Patang. So the how part of it, this is the steps. This is getting them to an action step that usually comes in the coaching conversation. It's helping them break down to, looking at what they can change. The example of a case example here is that I had an individual, and this often happens, where they don't have measuring cups in their home. They were told something by the doctor. They might understand some of that, but maybe not all of it. This is an example of a situation where I don't know what to eat. I talked to an individual about, what the doctor had indicated about carbohydrates. And the person said, well, I'm not supposed to eat very many of them. And I said, well, okay, what would that mean to you? What do you need to change? This individual now culturally, okay, would eat rice 3 times a day as a part of a meal, okay? And so they knew that they weren't supposed to eat so much rice. So in a situation like this, I said, well, how do you prepare your rice? What do you put it in? And the response came back that I put it in a bowl. And I said, so how do you measure it? I don't measure it. I just put it in a bowl. And I said, well, what do you put it in a bowl with? So I was just really curious with this individual to try to understand how does it actually look in their life? And so the individual said, well, I use a spoon. And I said, well, how big is the spoon? And so it was, it's about the size of my palm of my hand. I'm like, okay. So I said, so the doctor told you to cut down on the rice, and you know this. What could you do? Okay, you're telling me you don't know what to eat, but you do know what to do. Yeah. I said, so what would you be willing to do? And the individual agreed that instead of taking 3 scoops of rice, breakfast, lunch, and dinner, they could take 2. And so that was an example of a very small step change that this individual agreed to take. I also nudged this individual, and this is where I would ask permission to do this, and I would nudge them in a direction to say, so, have you ever checked your blood sugar 2 hours after you eat? No, never done that before. So in that small step awareness, this individual did check blood sugars and was able to see the difference in what was happening with their body in the blood sugar response. And so by this individual taking and realizing they could take 2 steps, this person came back and totally changed in how they were feeling and about their control, and realized they could do this. And this eventually went on to, we talked more about vegetables, things like that. So as we going through the path, but the individual felt empowered and was able to take some steps and actually lower their A1C in the long run. So that's kind of an example of how I would guide an individual with the language line. And as I said, it's not without its challenges in working with individuals with the language line, because it can be frustrating. My greatest advice probably is to remember this, is to always meet the individual where they are at, because they are an individual. And if we have an agenda and we go at it thinking this is hard, this is difficult, oh, I don't want to do this, it's always going to be hard and difficult, and you don't want to do it. And you're going to come across that way with that individual being short, curt. They're going to feel that. So I encourage you to put your pencil down and just listen and use the skills you've learned how to communicate or relate to somebody with motivational interviewing. If you haven't, I'd encourage you to kind of look at it as a way to connect with people. But if you let go of your agenda that you have to do something and do the best you can with what you are required to do, you might find that it's a better experience. It's less frustrating for you in working with people with the language line. So thank you very much for your time and letting me speak. And I think, go ahead, Patty.
Thank you. Go ahead, Patty. I was just going to pass it to you. Thank you.
Thank you, Marie and Hilda. Those were amazing. And we are running short of time, but I think we'll go through the questions that we have. And if we run a little bit over, people who can stay. And if you need to drop off, feel free to do that. Someone had a question, Hilda, about wondering how to make a referral for a CHW for someone who lives in the community. Do you want to talk about that? And I can talk about it a little bit too from the health plan perspective.
Thank you very much for that question. Usually when a provider is working with somebody in the community, the provider will connect with the CHW, and then the CHW will receive that referral. And that's basically what a CHW does. We receive referrals from within the community and also from organizations. And each process is a little different. So it just depends on what the need is. And if your facility has a CHW on staff, then I would recommend the client and that CHW talk to find out exactly what it is that they need, and then go from there, because every organization is a little different when it comes to referrals.
Yeah, thanks, Hilda. I think I would just add that there are some clinics that have CHWs on staff in their clinic, And so their clinician can refer them internally to a community health worker. It's also a benefit that's covered for Medicaid. So most of the Medicaid managed care organizations have resources that they could help refer somebody to CHW in the community. There are also community organizations, community-based organizations that have CHWs that are on staff that are grant-based. And so if there's not another way to find a CHW either in the clinic or another way, it might take some work to find something that's local, but there could be community health worker agencies that would be available to that person depending on where they live. So,
Patty, may I add a little bit to that comment that you just made?
Yep.
If there is no CHW on staff, you can always reach out to the Minnesota CHW Alliance. They're the ones that are like the holders of CHWs, and they have a lot of resources available for those looking to work with CHWs, and also support system for the CHWs already in the field.
That's a great resource, Hilda. They have, I believe they still have a roster of community health workers that are in Minnesota that have the certification.
That is correct.
Great place to go. Great. Marie, someone asked a question about specific tips for working with people just phone-based case management. So you went into a lot of detail and gave great examples. Do you have anything else to add about just phone-based work?
Well, it's kind of what I've done the last 12 years of my career. I prefer it actually than face-to-face, because it lets go of any kind of judgment that an individual has, usually between patient and the individual. But sometimes people need trust face-to-face, so that can be a challenge. It allows you to listen deeper, to understand a little bit better. And I would encourage you to, when you're asking questions, to really listen to what is the thing that they're talking about. What are they trying to say to you in the telephone conversation? And you have to remember that the agenda is not yours, it is theirs, and meeting them where they're at is really important. So if the individual is asking this question has not done motivational interviewing training, I would encourage them to do that, to really be able to listen at a deep level. That's what I've been trained to do for the number of years that I've done this, and it's been very, very, very valuable. Couldn't do this job without it. It's great. So
great, thank you. Someone had a question about, can you address perceptions of weight loss for diabetes? And kind of a follow-up question, how would a 10 to 14 day professional continuous glucose monitor be received? And that could benefit eating habits and acceptance of diagnosis.
Boy, that's a long one.
Yeah.
I have to read that one. Can you read it again?
Yes. Can you address the perceptions of weight loss for diabetes? Like I kind of assume they may be talking about different cultures and what their perceptions might be of the need to lose weight. And then the second part is about how continuous glucose monitor would be received.
Well, I think it depends on the culture to answer both of them. I don't know what the perceptions are unless I ask. So I would have a conversation about both of these in the conversation with the member. So if the member, I'm asking, how does an individual check their blood sugars? What do you use? That would bring me into some conversation about the CGM or the meter. If they're bringing up weight loss as a goal, I would have curious questions about that and go where the member wants to go with it. So I don't do a lot of research on the outside to understand, what are the barriers here or there. It's really always about listening to what is the concern that they have. I don't need to be the expert in the topic when I'm working with somebody in any coaching that I do. I really need to listen. What is the problem that they're having? Have them voice that, have me reframe that, reflect that, so that they could see if there's a possibility of how to change. So weight loss encompasses so many different things. Okay. And I'm sure every single one of us has tried to work on things for weight loss. So there isn't really one true answer. What's the best way to answer that? I think it's important to help, like when we're talking about differences in understanding carbohydrates, as Hilda was talking earlier, understanding different foods. It's really about what they feel they could do. Like the man said that he could eat less rice by using the spoon, okay? Or I could eat one less tortilla as an example to help them. They have to experience it to see what happens. So if their ultimate goal is weight loss, we need to have a very curious understanding of what they know and what they feel they need to understand or what they feel they need to try to make this happen, rather than me give advice on it. So I really try not to. We do interject things about healthy eating, exercise, stress management, and we ask permission to give it when it comes up. Okay. I'm hoping I'm answering that question. It's a long-winded response. Sorry about that.
That was great. Someone asked, they had a Somali patient who had gestational diabetes and needed insulin. And that person told them, if you take insulin during pregnancy, you're on it for the rest of your life, and they could not be convinced otherwise. So do you have any recommendations or suggestions for dealing with myths in the local community? Because people often trust some of those myths and their cultural connections.
As I said, this is part of the challenge in working in the community and working. I wouldn't say in the community. It's part of the challenge when you get the expectation that this and you can't change it. Okay, I can't write that, meaning that there's nothing I can typically do to convince that member else otherwise. That individual has to see the reason why. So I would have to be using some techniques to explore that, to even see if there's any possibility for me to get anywhere in that conversation. I can't or I won't is what I'm hearing in this, what you're describing to me, meaning is that this individual is pre-contemplative. They're not going to listen to anything that I say. So there's nothing that I can do about that other than maybe offer some information or send a resource on this. So if a care coordinator has the ability to do this and send something to them, that might be asking, would it be okay if I sent you some information in the mail on this? Okay, would it be okay if we had more of a further conversation with you about this with your physician? And because giving the direction when a person is in this pre-contemplative state, their door is shut. They're not going to let you do that unless you ask permission. And if the feet are in the ground, which I'm hearing they are in this situation, there's not much that's going to change unless that individual is willing to have a conversation about it.
Great. Hilda, do you have any other thoughts on combating myths and things like that?
I added my comment, not to interrupt Marie, in the chat, but it was mainly have a trained CHW that knows about diabetes education. I have taken a couple of paraprofessional courses, so I know a little bit. I know enough to help them understand, but I'm nowhere near a diabetic educator. But with my knowledge, I can sit down with them and talk with them and kind of explore their perspectives and where they're coming from. Did a family member have bad experience? Did they have bad experience at one point and now they're afraid to try it again? It's just a little bit more of getting to know where they're coming from. And kind of like Marie said, we really do have to sit down and have a conversation. And these type of conversations are not for the office, the clinic, because in the clinic we have 5-10 minutes, 15 at the most. And even with an interpreter, they're extended to 30, and that's already too long. So these type of conversations need to happen outside of the clinic. It could be in the office, but later, at a different time, where it's more relaxed, more calm, more stress-free, and both parties have an opportunity to actually dive into a discussion and then be able to gather the information and go from there. But it is something that once we explain it to them, we have to give them time to process the information. And like Marie said, they have to accept it. We can't really force them to do anything. So that's kind of where I'm coming from.
Great, wonderful. That is all the questions that I see in the chat. I'm going to turn it back over to Patag to wrap us up, and just to let you know that the evaluation link is in the chat, and it will also be emailed out with a reminder later on too. So take it away, Patag.
Thank you for the rest of you that were able to stay on as we are over time. Just would like to share a quick resource for you all on Cultural Care Connection. Please check it out. We will also follow up with the link in the email you will receive as well. This is an online learning and resource center that supports clinical and non-clinical health care professionals to reduce health disparities and promote health equity. We just would like you all to have this resource. And then lastly, this has been shared before, but we do have the evaluation link that can also be found in the slide deck as well in the chat today. Your feedback is important. Please take a few minutes to complete this. Upon completion, you'll receive the certificate of participation. And lastly, we'll send out information on where that recording and slide can be found if you need that information to view later on. But thank you everyone for your time, and we look forward to having you again for future webinars.